At the outset, I would like to thank DPH for organizing this, and thank you all of you who, at the end of a tired, long day, still sitting here waiting for tea to happen, and I am in between you and your tea for pontificating on urban health challenges, and so I will try to be as short as possible and as to the point as possible. And to take you forward, I will just, many of you might be thinking, why is it a coincidence that two people from UNICEF suddenly talked about urban health? And apart from purely coincidental, it is also an area of primary importance for us, as we are seeing increasing, and particularly because we are working in much of the states where urbanization is happening at a very rapid pace, and the health system is still grappling with the changes, and we feel that this is an important space for development partners like UNICEF to provide support and provide technical support and resources for the departments to overcome these challenges. So to set the context, what we would like to take you through is, if you take a look at the global evidence for urbanization, globally 2.5 billion people are to be added to the urban population by 2050. Slum population is going to get doubled by 2030 and is going to become a quarter of the world population. And by 2030, approximately 60% of Tamil Nadu would be urbanized. As per population projection figures from Ministry of Health based on 2011 census, but if past experience pans out, where we have seen urbanization happening much faster rate than anticipated in such projections. So we expect states like Tamil Nadu to urbanize much faster by 2030 than being at 60%. And if you drill down to the to identify how children are placed, you will see 350 million children are living in slum households across the world. 30 to 50% of the urban population is less than 18 globally. And to bring home the point, South Asia, particularly of which India constitutes a major share of the population, 61% of the slum population in South Asia is in South Asia, with large agglomeration of internally displaced persons, migrant workers, and refugees. And 9 out of 10 residents in urban areas now these days breathe polluted air, and we of late have seen they are also vulnerable to extreme weather events. So the urban paradox, which Rajeshwari also talked about earlier, is whilst urbanization is, urban areas are supposed to be well resourced, people are supposed to have better access, it's also seen that urban poor fare much worse compared to the rural poor, and in certain areas urban indicators might be lagging behind rural indicators, and we will unpack this as we go forward. So within India, if we see the locus of children, according to 2011 population, 135.5 million children are in urban India, which constitutes of total 35.9% of the total urban population nationally. And if we look at the state-wise distribution of this, almost 5 to 6 states constitute more than 50% of this urban child and adolescent population, out of which Tamil Nadu is one of the major states. Tamil Nadu, Maharashtra, UP being one of the leading states with large share. In 2018, keeping the urban focus in mind, UNICEF published a small report on while looking at 10 key SDG indicators on how urban children are faring compared to the rural counterparts. And in this case, we see these are the 8 to 10 indicators on which data from the DHS household survey has been used for 77 low and middle income countries to understand what are the relative advantages and disadvantages that urban children in urban areas uh, have. If you look at the data, you would see that water and sanitation and constitute a significant advantage, which has definitely knock-on effect on overall health attainment in urban areas. But if you look at the core health indicators, you will see that the urban advantages are not so much, and compared to the other indicators. And if you look at the relative advantage that we have over urban and rural, if you see with respect to immunization, particularly when we look at DPT3 immunization coverage, we see that urban does not have major relative advantage over rural, which means, which can indicate two things primarily. One is that the immunization coverage in rural has been exceptionally good globally, but it may also indicate that there are some challenges at the urban level where it is still lagging close to rural areas where infrastructure and services are considered poor. So, drilling down from there, if we look at the NFHS indicators for Tamil Nadu and compare the rural urban indicators, you see in certain areas highly urbanized and a state that mimics middle income country condition has significant advantage in certain areas, particularly with respect to sex ratio of children at birth. Children under 5 who has been registered, Tamil Nadu has perhaps one of the best system for civil registration system. Women who aged 20 to 24 years who were married before 18 years of age, Tamil Nadu is, urban areas are doing much better compared to rural areas. With respect to mortality rates, although this is the NFHS reported figure, the SRS figures are much lower, but to bring home the point on urban advantage on mortality, we see Tamil Nadu faring much better in urban areas compared to rural areas. With respect to mothers who had at least 4 or more ANC care, we see Tamil Nadu urban areas slightly lagging behind with respect to NFHS data. But it is not much of a gap, so as to say. And if we look at prevalence of diarrhea, prevalence of children who are underweight, all those indicators, urban performance is slightly better than rural areas, and one would have expected with higher resource setting, urban performance would have been much better in those areas. But if we consider some of the key indicators that constitute primary health and community health engagement in Tamil Nadu, we see with respect to some certain indicators, Tamil Nadu significantly or marginally lagging behind the rural attainments. This once again we see with respect to in NFHS 3 doses of Penta or DPT, with respect to children receiving first dose of measles containing vaccine, prevalence of acute respiratory infection in children under 5. When we look at prevalence of diarrhea, who has received ORS in the community, we see urban faring much quite significantly comparatively poorer than rural areas. And with respect, if you look at children who are, if you look at malnutrition in terms of obesity and NCDs, you will see urban areas are much more at risk than the rural areas. So which kind of begs the question, what are the key issues that we need to think through and what are the paradoxes? So in urban areas, what we really see, although and looking at those broad level health indicators do not really unpack the key issues, and here we need to drill down to data with respect to socioeconomic classification, location of household, which determines accessibility, and it also with respect to income and wealth, and we significantly see wealth effect and income effect in health attainments in urban areas. And if you and the picture that you see where is basically a stark reality of urban areas where inequalities are much more stark, where people have a group of people has better access to facilities including housing, health, water, sanitation, and a group of people with significantly challenged access to basic amenities can significantly impact health outcomes across the board, whether it be communicable diseases, non-communicable diseases, maternal and child health, any other aspects. The second part of it is your in any urban corporation areas, like suppose say Chennai Corporation, Mumbai Corporation, or Calcutta Corporation, you have large floating population. I mean, for these corporation areas, even during a particular time of the day, the population of the city will go up and then go down in the evening as people on a daily basis commute to these places for livelihood, for health care, for many other things, and may also pose can be a burden on a under served health system. So if you look at migration patterns, if you look at a floating population in urban areas, it is very difficult to identify key stakeholders who needs to be catered to with different kind of services. So there will be migrants who would come for work seasonally for 3 months, 4 months, 5 months, 6 months. They would access some health service, then they would go to a different state where they would access part of the other service. So their routine of complete health screening, health checkups would be incomplete in one place. They may be accessing it in another place or may not be accessing it in another place. This we see particularly in Tamil Nadu when we are looking at MCP cards of migrant population which they bring from other states. There are services that they are availing here, and they may or may not be availing the follow-up services in other places. And then when this population the next year comes back to these states, these receiving states, it becomes a challenge for the health system to identify what services are to be given, where are the gaps, what are the missing links. So floating population is a huge issue for receiving states like Tamil Nadu, where migrants come for seasonally and or occasionally. The third part is your multifarious health system vulnerability. We are seeing urban areas are hotspots for climate change and environmental pollutions. With respect to heat wave, my earlier speakers spoke about it. Urban areas are becoming heat islands where normally cities which were not known to have heat wave condition, but because of building norms, because of the built up area in urban areas and the use of air conditioning, you have heat islands being forming in parts of the urban pockets, which is in turn affecting the health of people. And you see, like my earlier speaker said, in Tamil Nadu there is a case of rise in heat related cardiovascular episodes going up, and I would not be surprised if this is more urban centric than rural centric. With respect to extreme weather events, with respect to vector-borne diseases, we have more construction sites coming up in urban and peri-urban areas which are very sensitive to conditions where vectors can breed, and like mosquitoes, dengue mosquitoes or malaria mosquitoes can breed and spread the disease. So this in turn puts much pressure on the health system, and unprepared health system. And you have a large group of people, including migrant workers, who work in hazardous occupations like Rajeshwariji mentioned, leather tanning, salvage yards, scrap yards, battery recycling, many such industrial belts surrounding urban areas where you have hazardous occupations. you have the population dependent on the health system for supporting for challenges with respect to occupational health. The final bit in our urban areas is the large presence of the private sector, from which the public health system has very constrained access to data and information on what kind of health services are provided, what kind of health checkups are provided, and in which it is very difficult to monitor quality, and in which most of the time it's the price is the only signal for quality, and that is what also drives even the urban poor to seek high cost healthcare, leading to further impoverishment and driving them into poverty. So these are the key challenges that we see in the health system, and that is why we need to focus on urban health in strengthening urban health systems. These are some of the key observations that going forward that we as UNICEF would work on, and would work with the department on some of these areas. We need to work on how to address informal sector and migrant population in terms of reaching the last mile gaps in urban health, public health services. We need to create more child responsive public health spaces. As we know, more and more children in states like Tamil Nadu are with reduced infant and neonatal mortality surviving beyond the first few days of life, and could face challenges with respect to child development. So more and more urban spaces which can improve the quality of life and development of a child's growth and development. We need a good data analysis of urban data, urban centric data, and use this evidence to for program monitoring and engineering our programs towards the goals that we need to achieve. We need an integrated approach and cross-departmental approach, because urban, like from the Mumbai model, has shown that it is not cannot be achieved by one department. It is cross-sectoral. The municipal administration, the Department of Municipal Affairs, in the capacity building organizations that work in urban space, urban planning organizations has to come into space, and urban health is not just dependent on one department. It has to be coalesced action across departments, and that is where coordination and partnership strategies are required. So I would end my talk over there. Thank you for your patient listening. Would be happy to take questions.
Working presentation, sir. The dais is open for questions. Now I invite our Joint Director of Public Health and Preventive Medicine, National Health Mission, Dr. Krishna Leela, to honor the speaker.